Tracy.
I'm Nir.
I'm Lanera.
I'm Sion.
And we're talking about
Methotrexate!
Oh.
Methotrexate is an anti-neoplastic and immunosuppressant. It is used to treat cancers of the blood, bone, lung, breast, head and neck, as well as psoriasis and rheumatoid arthritis.
All right, so now we're going to talk about the mechanism of action. Methotrexate competitively inhibits dihydrofolate reductase, which is the enzyme that converts folic acid to reduced folate cofactors, such as tetrahydrofolate. These reduced folates are required for metabolic transfers of 1-carbon units in some biochemical reactions. These reactions influence cell growth, including the synthesis of 5-methylic acid, DNA nucleotide precursors, and inosinic acid, which is a purine precursor required for DNA and RNA synthesis. So methotrexate is cycle-specific, and it inhibits cells primarily in the S phase. The S phase stands for synthesis phase. It's part of the cell cycle which inhibits DNA, or where DNA is replicated. So it occurs between the G1 phase and the G2 phase. All right, so methotrexate may enter the cell by one of two transport systems. The primary process is through the reduced folate carrier that has a high affinity for reduced folates and methotrexate. And the second is the human folate receptor, which has a higher affinity for folic acid versus actual methotrexate. Methotrexate may enter the cell also by passive diffusion. Once inside the cell, methotrexate undergoes polymerization to form methotrexate polyglutamate. Methotrexate polyglutamate has enhanced binding to the inhibition of dihydrofolate reductase, and due to its large size, has reduced efflux out of the cell. The process of polyglutamation happens more readily in tumor cells than in benign cells, which partially explains the selectivity of methotrexate for tumor cells. Methotrexate has immunosuppressive properties and has anti-inflammatory activity as well. It suppresses the secretion of interleukin-1, interferon gamma, and tumor necrosis factor. It impairs the release of histamine from basophils and decreases chemotaxis of neutrophils. Methotrexate may selectively inhibit replication and function of T and B lymphocytes.
So now I'm going to talk to you a little bit about the pharmacokinetic properties. Methotrexate can be administered parenterally, orally, and through the intrathecal route. It's partially metabolized by intestinal flora after oral administration, and hepatic aldehyde oxidases metabolize 10% of the drug to 7-hydroxymethotrexate. Once it's inside the cell, as Claudia mentioned, methotrexate can become polyglutamated. This process involves the addition of glutamate residues that alter the shape and charge of methotrexate. This results in accumulation of the drug and prolongs the inhibitory effect of the drug on target enzymes such as dihydrofolate reductase and other enzymes needed for DNA synthesis. About 90% of the drug is eliminated unchanged through the kidneys, and 5 to 7% is eliminated as the main metabolite 7-hydroxymethotrexate. Less than 10% of the drug is eliminated through the feces.
Some common adverse effects of methotrexate are hypotension, nausea, vomiting, and diarrhea. Patients taking high-dose methotrexate are more likely to experience myelosuppression, severe oral ulceration, thrombocytopenia, and nephrotoxicity. Myelosuppression, a condition in which bone marrow activity is decreased, is a major dose-limiting side effect for methotrexate. Methotrexate can also crystallize in urine and can cause damage when urine is filtered. Lastly, methotrexate can increase liver enzymes, and patients on chronic therapy are at high risk for cirrhosis.
Now let's talk about patient education tips. Patients should be aware of the possibility of serious toxic reactions which can be fatal. This drug should only be used in serious condition. Patients should be closely monitored for bone marrow, liver, lung, skin, and kidney toxicities. Patients should be informed by their physician of the risks involved and be under a physician's care throughout therapy. Methotrexate has been reported to cause fetal death and/or congenital anomalies. Therefore, it is not recommended for women of childbearing potential or if they are pregnant, and some experts recommend concomitant use of folic acid for low-dose methotrexate. When using high-dose methotrexate, patients should also be on leucovorin, also known as folinic acid. Patients should talk with their doctors before taking NSAIDs like ibuprofen or naproxen with methotrexate due to the potential of serious consequences. Patients should take the drug as prescribed and should not miss doses to gain the most benefit.
Thanks
For
Listening?
to
Us.
What questions do you have?